All right, I think we're going to get started. We've got about 90 people on so far this morning. Welcome everyone to our 2021 Healthcare IT Policy Landscape. This is some firsts for us. First, I'd like to acknowledge the chapters that are sponsoring this. Together, we've got Northern California, Southern California, and Oregon HIMSS chapters. So exciting for us to do a 3-chapter webinar together. Today, we've got some great speakers for you. I think it's going to be a great session. We've got Jennifer Stoll from OCHIN. We've got Jeff Coughlin from National HIMSS, and we've got Dr. Joaquin Arambula from the California State Assembly. So I'd like to start off with Jeff Coughlin to give us a national perspective on post-election healthcare IT and the policy landscape. Jeff's the Senior Director of Government Relations at National HIMSS. He comes to us from Washington, D.C. He's going to share a national perspective on COVID response, what's going on with the new administration from a healthcare perspective, and what we can expect to see in 2021 and beyond. Welcome, Jeff.
Thanks, Nancy, and thanks everyone for having me on this webinar today. It's very exciting and a very timely discussion. So I just wanted to start off by talking, as Nancy said, a little bit about kind of where we're at in terms of a COVID response, and then talk a little bit about some of the priorities as we know them now for the incoming Biden administration. And then I wanted to talk about some of the health IT, really key issues around health IT that I think we're going to be working to address over the next several months as we move between the Trump administration and the Biden administration. So I just wanted to highlight a couple things that were happening today. So the Electoral College is actually convening as we speak to formally elect Vice President Biden as our president. So you can see the Electoral College is meeting today. Also, negotiations on Capitol Hill are occurring related to the next COVID-19 relief package, and also on a kind of a year-end spending package around federal appropriation. So it's a very busy day here in Washington. So on the next slide, as I said, I just wanted to talk a little bit about where we're at in terms of planning related to COVID-19. And we have moved, obviously, to the vaccine distribution stage of the COVID response. And that's another big kind of milepost for us here today, as today was really the first day that vaccines have been administered several places across the country. So the plan that the Trump administration and Operation Warp Speed have really put together kind of highlight some of the key tasks that they have underway. And as a health IT, healthcare transformation organization, I wanted to kind of highlight the last point around where we're at in terms of a vaccine and a vaccine distribution program, and just about monitoring the necessary data from the program through an IT system capable of supporting and tracking the distribution, administration, and other data. So what we're talking about really relates to ensuring that health IT is really leveraged appropriately as we think about distributing the vaccine. So on the next slide, just talks a little bit more about some of the things that the Trump administration has put forward, and the Operation Warp Speed, which has really been in the driver's seat of a Trump administration response, and what they're thinking about related to IT. And that has to do with the ordering and tracking of the vaccine, how it's going to be allocated, distribution, also about onboarding providers to make sure that everyone is set up to actually administer the vaccine in a timely way. IT is also being used will be used for the public around help finding a vaccination site once we get into kind of the wider scale. And then probably most importantly, where IT is going to be significantly leveraged is around monitoring, around the data monitoring infrastructure that's going to be required in terms of appropriately using IT infrastructure for just the claims and payment processes. Also, the idea of of the Pfizer vaccine, as most folks probably know, requires 2 doses. So folks are getting their first dose today in a lot of cases, and then in a month's time or so, they're going to have to come back for a second dose. How that works and kind of the back end and on the administrative end is, I think, going to be require some Herculean efforts from across the healthcare enterprise. So that's something that I think that IT can be a significant driver of that. And then also in terms of monitoring the outcomes and any adverse events that may come up as this is administered wider, across the population. So I would just say that I think that the idea of making sure that data is a key part of this. IT is a key part in making sure that the data is available, accessible, for kind of driving home this broader the broader vaccine distribution efforts. So on the next slide, just includes some recommendations that the Department of Health and Human Services has made related to what we're talking about related to actually receiving the vaccine. Who is going to be eligible when? Right now, as doses are kind of limited at the beginning of our time frame here, we're going to be talking about healthcare workers. First responders are going to be first in line in terms of. But as distribution and availability scales up, then that makes it broader availability population. And folks in nursing homes, other folks that may have pre-existing conditions will also be kind of prioritized. And then it kind of scales down from there. What the way HHS has structured things currently is to really try to make recommendations to states. The CDC, the Centers for Disease Control and Prevention, has made recommendations to states around how they might want to distribute their different structure, the distribution of vaccines. So that's something that we're watching very closely. On the next slide, I just obviously since the election, the Biden-Harris administration has really tried to come up with an idea of where they would like to see the COVID response shift once they come into office on January 20th. So what they have been talking about is a 7-point plan. And the idea would be around making sure that all Americans have access to regular, reliable, free testing, that we really try to centralize a federal response to ramp up the production of masks and face shields and other personal protective equipment. Also, the idea of directing the CDC to provide clear, consistent, evidence-based national guidance, specific guidance that would help people navigate the pandemic for schools and small business and families. Also, the idea of a planning for effective, equitable distribution of treatments and vaccines, and making an investment into a vaccine manufacturing and distribution plan, protecting older individuals and others at high risk, rebuilding and expanding defenses to kind of prevent and predict and mitigate any future pandemic threats. And then also something that I think most folks have probably heard is around maybe a nationwide mask mandate and working with state and local leaders to implement something along those lines. So that's where their thinking is now in terms of a response. I think it's evolving, and as the transition planning between the Trump administration and the Biden administration has continued to grow and expand, I suspect that we'll be getting more information on how a Biden-Harris administration expects to deal with COVID response come January 20th. I think the biggest thing that I would just say in terms of COVID that folks and public health officials everywhere have really emphasized is a vaccine is great, but what we really need to talk about is vaccinations. And a vaccine sitting on a shelf is not going to help us get out of this crisis. We really need to figure out how to get everyone vaccinated. So that's just something that I would emphasize and really try to hit home the point about IT's critical role as we do that. So on the next slide, I just wanted to highlight some of the things that the Biden administration talked about. The President-elect Biden on the campaign trail really tried to talk about and tried to hit home in the kind of lead up to the election. A lot of these priorities that are on here, I think, are still in the process of being fully fleshed out. But what Vice President on the campaign trail really tried to talk about was building and expanding on the Affordable Care Act and creating a public option plan and trying to create some sort of premium subsidies for those folks that were kind of not in that income bracket where they would be eligible for any sort of Medicaid expansion subsidies, or would kind of fall into other categories where they may be eligible for some help to pay healthcare premiums. So the idea about expanding ACA premium subsidies was something that that President-elect Biden talked a lot about on the campaign trail. He also tried to talk about lowering the Medicare eligibility age to 60, try to open up the program for those between 60 and 64, negotiating drug prices, allowing the Medicare program to negotiate drug prices, and also making long-term investments to scale up drug addiction treatment, other prevention and recovery programs. Those are all things that he spent a lot of time talking about. And when during the Obama-Biden administration, the vice president was really on the front lines of developing the Cancer Moonshot Project. So, and also the idea around precision medicine. So I think we expect to see an opportunity to really think about precision medicine and Cancer Moonshot down the road as the Biden administration gets its footing moving forward. So the other thing on the next slide, I tried to consolidate into some of the issues that I think that we see at HIMSS as the must-address issues for 2021. We've already talked a little bit about the COVID-19 response, so I won't really reiterate anything there, except to say that one of the things that the Trump administration has really tried to de-emphasize is the idea around collaboration with other countries and with the World Health Organization. So we see this as a real opportunity for the Biden administration to get the U.S. better engaged again with the World Health Organization, figure out sharing of model practices and lessons learned with other countries is also something that we see as critical moving forward. Some of the other issues that we think are going to be high on the agenda for the Biden administration and for Congress is around data privacy and digital competition. The idea that we'll talk in a little while around a new proposed rule that we got related to the health and the HIPAA rules is something that how we figure out conflicts between federal and state laws related to privacy is something that I think that folks have talked for several years really needed to be prioritized. So we see that pretty high on the agenda for many folks. And the last couple of things that I'll mention that I won't cover in the future is the idea around focus on value-based care. This was an idea around value-based care and the focus more on outcomes rather than the volume of care that's delivered at frontline practices. But the idea of delivering better outcomes to patients is something that has been talked about since the Obama-Biden administration through the Trump administration and really is going to I think, continue to grow and expand in the Biden-Harris administration. And then the idea around equity issues, around social determinants of health, maternal mortality. As folks in California probably know, Vice President-elect Harris has a real focus on maternal mortality. So we see that issue really coming to the forefront. And then also when we think about broadband subsidies and making sure that folks not just in our urban areas have access to the internet, have access to everything that telehealth and remote patient monitoring can offer. That really comes into play related to broadband subsidies. So really quickly on the next couple of slides, I just wanted to talk a little bit about telehealth and drill down a little bit on what we're talking about related to telehealth. So at the beginning of the public health emergency, folks probably know that what we did in the U.S. was really expand and provide policy waivers around how telehealth could be administered across the healthcare ecosystem, across providers. And the idea on when this public health emergency actually concludes and expires, we want to make sure from a HIMSS perspective and a lot of other organizations that we're working with, that we have kind of a smooth transition, that there's some stability. Overall, patients have been really happy and excited and really on board with the idea of using more telehealth in kind of response to COVID, and also to kind of suit their personal needs. So I think what we want to ensure is that there is a transition, that what we're doing is we're retaining some of these waivers as we figure out kind of a longer term plan and try to really make sure we're delivering care in a manner that patients want. On the next slide, some of the things that we want to see become permanent policy have to do with lifting the originating site restrictions in the Medicare program related to telehealth, and geographic restrictions, and allowing clinicians to reduce or waive potential cost sharing obligations. So these are all things that are in place right now, that patients are taking advantage of, clinicians are learning to access, and we want to make sure that there is some sort of glide path as we think about broader care delivery and broader reforms in the future. So on the next slide, I just wanted to talk a little bit about the interoperability work that's underway. Folks will probably know that we have 2 rules that have come into place in March of this year from the Office of the National Coordinator for Health IT and the Centers for Medicare and Medicaid Services that relate to expanding and facilitating broader interoperability and ensuring patient access, ensuring that innovation and that application programming interfaces are part of what we're delivering to patients, and allowing them to access their information and greater control over their information. On the next slide, what happened, as I mentioned, these rules were finalized in March, right about the time that that COVID was gripping the entire nation. And so the rules were published in March in final form, and then formally published in our Federal Register in May of this year. But in the interim, before they were formally published, what ONC and CMS said was that the timelines that we originally had put into place to get these rules implemented and applicable and enforced was going to be too tight, which really was going to occur later on in 2020 and early in 2021. So ONC and CMS put off the formal implementation of these rules, while at the same time really encouraging providers to continue to move forward with implementing them if they were able to in the face of the flow of patients related to the pandemic. So what ONC did come back in late October of this year, actually, and extended the deadlines even a little bit further for several of the provisions. Again, they want to recognize the importance of interoperability and broader data sharing in the face of a pandemic and how helpful that could be. But they do realize that not all healthcare organizations are really going to be able to implement these in a timely manner at the same time that they are dealing with so many other issues related to the pandemic. So this was kind of a happy medium of putting off the full implementation of these rules. On the next slide, I just want to run through 2 new rules that have come out related to kind of the tail end of the Trump administration. We can talk about these a little bit later in the kind of context of the Q&A, but suffice it to say that Trump administration is still continuing to push forward relating to new kind of interoperability rules, additional rules from the Centers for Medicare and Medicaid Services, and changes to the Health Insurance Portability and Accountability Act, privacy rule. So, Jen, I'm going to turn it back to you for kind of the Q&A, and happy to touch on these issues in the future.
Thank you, Jeff. I'm going to turn it back to Nancy. I didn't know if she wanted to.
I do want to take a minute to introduce you, Jen, to the audience. Jen is the Government Relations and Public Affairs person for OCHIN. She is a leader in the intersection of health, IT, and policy, and we're excited to have her with us today. She spends her time both in Sacramento and in California policy, as well as she lives and breathes up in Oregon and spends her time with the Oregon chapter in the Oregon state as well. So welcome, Jen, to our event today.
Thank you, Nancy. And thank you to the tri-chapters of HIMSS. As Nancy mentioned, I'm Jen Stoll. I lead government relations for OCHIN. We're a nonprofit health IT organization supporting safety net providers all across the country. And today we are very, very lucky to have Dr. Joaquin Arambula with us. Dr. Arambula is an emergency room physician who is serving in the California State Assembly, representing the 31st Assembly District, which you would know as a good chunk of Fresno and surrounding areas. He is the first Latino physician in the California Assembly, and he chairs the Budget Sub-1 Committee, which for those of you who may not know what that is where the finances of healthcare go through. So we're really excited to have this conversation with Dr. Arambula and gain his insights on what's happening in Sacramento. And Dr. Arambula, thank you for being with us this afternoon.
Thanks for having me on, Jen. I'm looking forward to the conversation.
Wonderful. Well, as you know, we are in a transition period, and we would love to get your insights on what's on the California legislative agenda for the coming year, and as we have a new administration coming in with a different healthcare focus.
Thank you. And if I can, I would like just to take a moment to introduce myself. I have the honor and privilege of representing the Central Valley, which is the breadbasket for the entire world. And I spent 10 years prior to running for public office as an emergency room doctor, where I also served as medical director, informatics director, and worked quite a bit on making sure that technology was helping us to meet the needs of those who are working on the front lines. But it's now in my role as a state assembly member that I come before you, and really would like to provide a little historical perspective if I could, because I think it helps to ground us in what we are facing now. This is what many of us have termed the pandemic of the century. And if we look back to the Spanish flu that occurred in 1918, what we can learn from that is the deadliest part of that virus was September to December of 1918. It is in that same window that we are in the midst of right now. And so I just needed to say it, and it probably goes without saying, the need for us to be vigilant and socially distance and practicing what everyone is preaching right now. But what I really wanted to speak to is about disparities that we're seeing specifically within communities of color. I have made it my life's work to fight for health equity, and it's difficult when you are seeing those racial disparities occur in real time. And so I've been spending much of my time making sure that we have the appropriate metrics and are looking at data and are driving resources towards communities that have the greatest needs. But I will speak to, since you referenced this upcoming year, the need for us to make sure that we are meeting this, what I like to term our defining moment. Just like FDR met the moment after the Great Depression, what we saw was a need for policies that are making sure we are taking care of our community and our constituents. What I am seeing too often in my community, a poor farm working community, is that people are having to make a very difficult choice between putting food on their table or going or exposing themselves and their families. And so what I believe we need to do during this crisis is make sure, just like they did with the New Deal, that we have a shift in who has final responsibility for our community and our citizens. During this pandemic, what we've seen is that we're going to need to be in this together, that the health of each of us is dependent on the health of all of us. Now, we have heard and had politicians speak about how healthcare is a human right, but how we actually make that a reality is fighting for universal healthcare. And it's why I think in this upcoming year, our most important policy will be to fight to increase access to all people who are in our great nation. And one of the best ways we can do it to help my community would be to actually enact immigration reform so that we can bring many of the communities of color who are being deemed essential, and yet many of our policies treat them as if they are expendable. I think it's important for us to elevate the concerns of those who are most vulnerable during this pandemic and really have enjoyed working on this. I never would have thought when I ran for office half a decade ago that we would have this pandemic of the century. And yet it will take those of us who have practiced, those of us who can interpret the data, those of us who can make decisions based on it to make good public policy that will move the state of California forward.
Thank you, Dr. Arambula, for that context. Very, very helpful, and also truly appreciate the health disparities conversation. So do you have legislation you are going to advance this year that you would like to talk about to the group? And what else do you see being introduced this legislative session that might help close the disparities gap?
So first and foremost, we have been working on a movement to fight for health for all. This is the fourth year that I've introduced the legislation. I know they've been working on it for nearly a decade. Now, for the successful parts of the story is we've been able to expand healthcare coverage to our undocumented children and young adults. This is a significant achievement for us to help to build the resiliency and prevent the long-term health complications that can exist by spending effectively at the start of their lives. Now, I believe we need to actualize this plan and have a commitment from our governor. And so we're asking him this year if he can achieve that within his governorship. And if he is going to achieve that, then we'd like a down payment this year for us to start working towards that. Much like we're hearing with the Biden administration, who's looking to increase access. I believe we need to continue to chip away at those who are not covered currently for us to make effective changes in public health.
Thank you. And I want to encourage everyone, if you have questions for Dr. Arambula, please enter them into the chat. We would love to hear your voices as well. In the midst of the public health crisis of COVID, we know that our communities of color are being hit in higher occurrence than other communities. Do you have any thoughts on what the health IT community can do to help support your work in health disparities and health equity?
Yeah, so I've been really impressed with the state of California, and I've been pushing them, and they are really on the cutting edge, and they have a health equity metric that is a part of our tiered system for counties to be able to advance that allows us to get more regional census tract information to then drive resources towards communities that need it the most. I would want to make sure that this metric was well-serving. And frankly, I think your group would have an ability for us to determine if it's being effective and is a good tool and something that should be looked at to be scaled to other states. But I believe that is a great example of something that California is trying to innovate with so that we can affect those health disparities in real time.
Great. So we have a question from the chat from Dr. Lane from Sutter. Dr. Arambula, does having Kamala Harris, Senator Harris, with her California perspective in the White House, do we anticipate any specific changes in federal health care policy as it relates to California?
So I always think it's helpful for us to have Californians in the White House, and Kamala has been wonderful, particularly because she served in statewide office here. I know she has an interest. I share her interest in maternal health. We, particularly in Fresno, have a real issue with African American maternal mortality. And believe, again, we have to really focus on social determinants of health and need a federal partner who's willing to help us with resources to make sure we're uplifting all our vulnerable communities so that we can work on some of these issues that have been plaguing our communities for a very long time. But while you mentioned Kamala, I don't want to miss a chance to mention Javier Becerra, who is one of the reasons why I am in public service now. I heard him keynote at an Insure the Uninsured project a number of years ago and asked him while he was there if I should run for office. And so now, sitting in office a number of years later, it's nice to know that he's going to be in our state's capital as Secretary of HHS, because I believe I know where his heart is and how he's going to push to increase access and to make healthcare more affordable and accessible for communities will really be a comfort in this upcoming administration.
Thank you. One last question from the chat. With your personal background in informatics, how does your understanding of informatics inform your policies and potentially a legislation that impacts health technology and health IT?
So I'll mention one that popped up when Jeff was speaking, if I could. So you were talking about vaccine distribution and the need for us to promote vaccine confidence. And so just 2 weeks ago, we heard from UC Berkeley's Department of Public Health, who did a study of farm workers in Salinas. They interviewed over 1,000 of them. And the study showed that 48% of farm workers were not likely to get the vaccination. Well, for us to make good public policy, we need to respond to that information. And then, just as Jeff was suggesting, to get ahead so we can build the confidence into particular communities who we deem as essential and are having issues, disparities occur during this pandemic. And so that's just one example of how we can react to the data. And I'm quite excited. I reacted to vital signs. I think we in public service need to make sure we're reacting to real-time information as well.
Excellent. Data-informed outcomes. We like that. We're going to shift gears a little bit to talk about public health emergency and flexibilities that were given during the public health emergency, and specifically telehealth. We'd love to understand your view on telehealth and how we can work to allow telehealth to improve access to care in underserved communities and identify any policy priorities for 2021, 2022.
So first and foremost, I'm a believer. I see the need for us to increase access, particularly for our rural communities and areas that have historically had provider shortages. Representing one of them, these are only being magnified and exacerbated during this pandemic. And there is an opportunity for us to rise out of it stronger and to realize that telehealth is a major part of that. And so I am very supportive of making sure we have the same payment parity and flexibilities that we had last year, as they greatly helped us to increase access in, say, behavioral health as an example within many of our clinics. And so for us to make sure we are doing all we can to increase access to care, I believe we need to continue the supports and flexibilities that we had during the pandemic. Now, I also think there's a chance for us to see the future, which is if we can do distance learning, why can't we do social emotional learning right now as well? Why can't we connect you to behavioral health so that we can support and give you the resiliency when we know our children are experiencing many of the same fears and anxieties and depressions that we all are? And so would hope that we can see the chance to align telehealth during this crisis so that we can better meet the needs of our kids would be a great issue for me to continue to work on and push for. And so I've historically been very involved in working with ACEs, and here in California, we have a Surgeon General who's very involved with this as well. But what we've struggled with is if you screen for trauma, how do you then appropriately send them to services if you're not supporting effectively telehealth? And so I see a real opportunity for us as a state this year to meet a need. And for us to meet this moment will require us to make sure we are making the appropriate investments. Now, I would be remiss not to say that we as a state have a great need for infrastructure, for us to build the backbone that's necessary to transmit the information, particularly amongst health information. I know how important it is for us to be able to have that infrastructure, and it will take investment for us as a state. But what I think you're seeing here in California is real momentum. You're hearing our leadership in the houses as well as our governor continue to bring up the need for broadband for all, for us to increase capacity in our state. And frankly, I think it's how we're going to help to get our economy back up and running, is by making some of these important investments in infrastructure.
That's great. Investments in infrastructure are critical. You talked a little bit about broadband. Any desire to look at helping organizations with improvement on their electronic health record structures, or improving the IT infrastructure of public health departments?
I'm happy to hear ideas. I am in that creative part of the year. And so any chance you can connect with my team, I'd be happy to discuss. I was very pivotal in our selection, and frankly then became the person who educated our providers on how to interface with our EHRs. And so I'm quite well versed and would be happy to have future conversations on it.
Great. The next question is in that similar vein around HIT infrastructure, and it's specifically talking to registries. Can we support additional registries to rapidly respond to the next infectious outbreak before it becomes a pandemic?
That's a great one, and one I know I have quite a bit of interest in. I've been working on a Parkinson's registry here in the state of California that's currently in a pilot form, but will need to be codified, and it's something my office is looking at. And know there is great need for us to look at that information. I'll just highlight one here in the Valley that has me interested, but specifically, we have something called valley fever here in the San Joaquin Valley. It's coccidiomycosis. It's a fungus that exists in our dust and it's in Southwest and in other parts, but isn't prevalent throughout the country. But valley fever is very cyclical, and oftentimes we can determine that there are periods where we're going to have more exposure, and we could learn from a registry to better understand the disease process so we could then inform the public about some of those risks. So I agree with you and see the need for us to continue to look at these disease processes, and am a systems person at my core. I see us as systems. It's cardiovascular, pulmonary, neurologic, and it allows me to see the state of California and what we're doing with systems. And frankly, with public health, I see a real need for us to, in medicine, we did M&M reports, morbidity and mortality, for us to look back and determine how our public health system performed and whether or not there are improvements is the discussion that I believe the state of California will be having over the next year so that we can make improvements to prepare for the next emergency to come.
Great. The next question comes from Dr. Eisenberg from Stanford. Will the legislature try again and build up broadband infrastructure and access in rural and underserved communities so that patients can successfully use telehealth and students can access education online?
I would anticipate, I know I've signed on as a co-author to my colleague, Aguiar Curry, who has introduced a bill along with Lena Gonzalez. And again, when we have leadership and the governor all pushing us in a direction, we're moving in a positive direction. And I would hope we are able to get there this year. And believe you're right, that this moment is ripe for us to have that conversation with people who are all recognizing the advantages of this new medium while I'm sitting here in my house, able to have this and do this, as I'm sure each one of you are appreciating as well.
Great. So, Dr. Arambula, I want to give you some time to talk about what I may not have asked you, and specifically, how can the tri-chapters from Portland down to San Diego of the HIMSS, and when you have Jeff also online from DC, how can we help support your agenda in Sacramento and be better stewards in California? How can we support you?
So, first and foremost, I have strongly and always believed in us having better data. So how we can make sure that we are reacting and making informed decisions is dependent on us receiving the information from groups like yours. And so would love to be able to continue to be able to program and work with you. But frankly, it's why we continue to have disparities with sexual orientation or gender or specific communities of color, because we're not asking and looking at the information and then making decisions and basing resources off of that. But to answer your question specifically, I really am curious about the long-term effects of COVID-19. I think many of us can see the window of COVID-19, but what's the longitudinal study? What happens with the long haulers? What happens with the kids who may develop autoimmune diseases and have sequelae downstream? And how do we track and follow that is something that we're going to need our information systems to help us with. And so I'm quite interested, as I believe that will be an area that's ripe for helping us to make good public policy.
That's wonderful. I'm going to shift now. Thank you so much for your input. We're going to open it up now to a panel of you and Jeff. But there's a couple of questions in the chat directed to you, Dr. Arambula. So as we are transitioning, CalReady has lots of data, but each local health department accesses it and ingests it differently, the data differently. What kind of scalable standards do you think we could move toward in the state so that we have uniformity across all the local public health departments?
Well, I would hope that there aren't 58 different best practices that are occurring, as we have 58 different counties, but instead could learn from those that are doing the best. And frankly, that's informing and reacting to the information. I was representing Fresno County, was able to see the surge that occurred in July before we were a hotspot. Now, sometimes it's because you're actually paying attention to the information, but I am not always sure that we as a state are able to do that when you are receiving it from 58 different counties. Now, what I will share without completely answering it, because I think the administration has to take a leadership role in it, will be to make an anecdote, if I can, an analogy. I would not have wanted to go to an ER where I had 58 different doctors who were making orders on me. And am appreciative that we've had a governor who's been leading on this issue, and that Dr. Ghali has provided very clear public health guidance, allows me to see a need for us to really centralize much of that decision making so that we can improve the outcomes long term. And I'll just leave it at that.
Thank you. So at this time, please enter any questions into the chat for Jeff or Dr. Arambula. The next question is coming from Dr. Lane. CDPH needs resources in order to upgrade CalReady. This is necessary for them to be able to ingest voluminous electronic case reporting data that's being sent over from the APHL hub from healthcare providers. Can state government assist them in getting their upgrade done so that providers can stop parallel manual reporting?
Jeff, I don't want to monopolize the panel. I will say it is shocking to me when CDPH has been asked to do so much more that we haven't been supporting them with more resources during this time. And so would agree that there's a need for us to make investments to support them in their work.
Thanks. And the next one goes to Jeff, actually, and is talking about National Patient Identifier. I know there's some conversation about California having their own unique identifier. Can you talk a little bit about what's happening in DC about the National Patient Identifier?
Sure. Thanks, Jen. So not to get too much into the weeds in terms of, discussions in Washington, but there basically has been a ban placed on federal level discussions related to a national patient identifier through the federal appropriations process for about the last 20 years. So what that has done is really tied the hands of anyone at HHS having discussions related to a patient identifier. What we have been trying to do at HIMSS, and we have a whole coalition called the Patient ID Coalition, that is really focused on trying to get that ban lifted so we can begin discussions around that. One of the things that we're going to be pushing for, we've been pushing for the last, over the course of the year, and OCHIN has been very involved in, is a lifting of that ban and really focus on developing a national patient ID strategy so that we can begin discussions around that and figure out what the best path forward is. What ONC just announced, the Office of the National Coordinator announced just a couple of weeks ago, that they were going to be looking at trying to standardize patient level addresses, to try to help mitigate some of the issues that we have with patient ID, and that is kind of the beginning of dipping our toe into the water in terms of looking at this. But this is something that developing a strategy is something that we really think could go very far in terms of making sure that we have information at the point of care to really treat patients moving forward. So it's something that that we're looking closely at, trying to work with folks on Capitol Hill to get this addressed.
Great. Dr. Arambula, are you hearing anything about a unique California identifier?
No, I'm not, and would defer to Jeff on that.
Great. This is a question back to Jeff, talking about the opportunities for Javier Becerra being the new HHS director. Any word on when he may appoint heads of CMS or ONC?
No, I mean, I've heard anecdotally that the things discussions are being had related to that. I know that Mr. Becerra, I think, is in a pretty unique position, being a member of Congress, of the U.S. Congress for several years, and transitioning to state office. So I think that he has he's had a lot of opportunities for interaction with some very high level healthcare leaders that I think will figure prominently in discussions moving forward in terms of all the agency heads. So I think over the next several weeks, as we move forward related to more cabinet level positions, then I think as those discussions continue, we'll get more information around HHS agency heads, et cetera.
I know I'm quite excited to have someone who has voted for the ACA and
Right.
also has defended it in the Supreme Court as being the head of HHS. As again, it bodes well for us continuing to increase access and making improvements in healthcare.
Yeah, and I would say too, just to add on to that, Dr. Arambula, I think that someone reminded me this weekend of how really California has taken advantage of federal level waivers in terms of design, like you were talking about, designing your Medicaid plan, et cetera. So I suspect that that Mr. Becerra will continue kind of those themes when he's the head of HHS to kind of look at state level innovation and how we kind of foster that and how we really make that real and deliver better outcomes for patients. So I suspect that that'll be a centerpiece of kind of a Becerra HHS.
I'm going to ask one more question as we're getting to the end of the hour, and I'm seeing no more questions in the chat. So as we move beyond the pandemic, and obviously we have more time in front of us of dealing with the pandemic, what do you think from the public health emergencies? What would we like to see maintained from the PHE? And what do you think will be tossed out or redefined? Jeff, we can start with you in DC and then go to Dr. Arambula and from a California perspective.
I think first and foremost, we would like to see some of the waivers related to telehealth and remote patient monitoring really continued and some sort of permanent solution around that. As we talk about disparities and kind of care delivery, I think that the telehealth has an opportunity to make sure that that we are kind of treating patients where they're at, making care more available to them. So I think that any sort of flexibilities around greater telehealth delivery is going to be something that will remain high on our agenda once the public health emergency subsides.
I'm going to use right over here as JFK, and he's got a great quote that was attributed to him where he spoke about the Chinese character for crisis. And he said it's two words, it's danger and opportunity. I think all of us see the danger surrounding us with COVID-19, and yet there's also opportunity for us to make improvements. I alluded to it earlier, and so I will just be explicit about it. But this is the second largest economic downturn we've seen in the last 100 years. So if we look back towards what occurred during the Great Depression, we saw a shift. It was actually a shifting of final responsibility to government for its people during these tough economic times. Now, my hope is that after this healthcare crisis, we see an opportunity for us to fight for healthcare for everybody. I think that's how we improve upon our systems. I think that's how we shift again that responsibility, because ultimately we bear the responsibility anyways. Having practiced in an ER, they just end up coming in sicker and they die sooner, and believe we are a better country than that and know we can do better. And so my hope is that there's an opportunity for us to realize that we don't want to have that danger in the next emergency and the next pandemic, and that we can improve upon it by creating a healthcare system that works for all of us.
Wonderful. Well, on behalf of the Tri-Oregon HIMSS chapters, Oregon, Northern California, and Southern California, thank you so much for joining us today, Dr. Arambula and Jeff. Really appreciate your insights. We stand to support you. There was a question in the chat on how best to reach out to your office. What would you like, and how would you like for us to work with you? Because I know this group has lots of ideas.
Well, I'd like to highlight, I have a wonderful staff member, Arusa Ahmed, who's been with me for a number of years and staffs me on all of our health-related issues for the budget subcommittee. And she's on this call, so if she would put her information in the chat, she would be the point of contact and the best person to reach out for setting up for future meetings or communicating.
Thank you. And with that, I'm going to turn it back to Nancy to conclude the program.
Okay. Can you guys hear me? I just want to thank our speakers today, Dr. Arambula, Jeff Coughlin, and Jen Stoll. This has been a great event. I also want to note that this event has been recorded, so we will be sending out a link and following up with some information to all of our chapter members about how to access this recording. Thank you so much for joining us. I think it was great to hear both the national and the local perspective on what's going on. And I am looking forward to all the good news I think we heard today for those of us who are focused on advancing healthcare for all and leveraging health IT. This has been a great event. Thank you so much.